so I'll take a break from our resident talks, and we are extremely excited to welcome one of our own back. This year, we're privileged to have Dr. Nikita Kohli, illustrious member of the class of 2018. And I think I see Dr. Kaplowitz here also. Not quite as illustrious, but also a member of the class of 2018. Couldn't get a Bromwitz. No. So Dr. Kohli has graduated from Northwestern University with a degree in biological sciences, and then went on to the University of Virginia School of Medicine. Then, of course, most importantly here at SUNY Downstate, where she graduated, as we said, in 2018. And then went on and did her laryngology fellowship at my alma mater, the New York Center for Voice and Swallowing with Dr. Blitzer, and now is assistant professor of otolaryngology at the Yale University School of Medicine. Dr. Kohli has been on numerous committees throughout the academy, including the Bronchoesophagology and Laryngology Education Committee, the Airway and Swallowing Committee, and the Women in Otolaryngology Committee. She's a postgraduate member of the ALA, ABEA, and Triologic Society. She's pretty much been a fixture at all of our COSM and annual meetings with multiple oral presentations and poster presentations and mentoring of students and residents. She's a peer reviewer on Laryngoscope and several other journals, and I think really is sort of the role model for what a young professional is in our specialty, and what sort of the residents should sort of aspire to in the early portions of their careers, getting involved in mentorship and leadership and in the academy. And we're certainly super proud of all of her accomplishments. So a warm welcome back to Brooklyn for Dr. Kohli.
Thank you so much, Dr. Benciano, for that kind introduction, and thank you all so much for the opportunity to speak today. It is wild to be back at Downstate after all these years, so it really is an honor and a privilege to be back. So for my talk today, I thought I'd talk a little bit about recurrent respiratory papillomatosis, really looking at overview of the disease, but really focusing on emerging strategies for treatments and as well as pulmonary manifestations, which has become an interest of mine that is present but really understudied. So we'll start off with a little bit of background, talk about management, emerging therapeutics, and then finally end with a little bit about pulmonary disease and some of the work that I've done in this area. All right, so we know RP is a rare disease. It's classified as an orphan disease, typically due to the infection of the aerodigestive tract with HPV types 6 and 11. 95% of cases are going to be due to those types. Two forms. Juvenile onset typically happens from vertical transmission from a mom to child. Adult onset is felt to occur due to reactivation of the latent HPV virus or via sexual transmission. Phenotypes vary quite tremendously. Some patients may present with hoarseness, others may have severe respiratory distress requiring tracheostomy, have extensive tracheal or pulmonary disease. Typically, the disease is going to have a predilection for the larynx. It has a predilection for the junction of stratified squamous and respiratory columnar epithelium, but it can extend distally to the trachea and bronchi as well. Typically, it's going to have a trimodal distribution. It's going to happen in juvenile onset. There's another peak around 20 to 40 years of age, another peak that occurs later in life around the age of 65, with an incidence of about 3 to 10 in 100,000. I won't belabor the basic science too much and bore everyone, but I do think it is important as we talk about emerging strategies. So HPV 6 and 11 are going to encode the E6 and E7 oncoproteins, and typically these inhibit the P53 and PRB. And because of that, it leads to dysregulation of cell proliferation. 6 and 11 are thought to bind those with less efficiency than some of the higher risk HPV subtypes, and for that reason, it's felt to have less efficient malignant transformation. The interesting thing about HPV and RRP is that HPV is ubiquitous. Over 80% of women are going to have diagnosed or going to have had HPV by the age of 50, and most people clear the disease. Why a very small subset develop papilloma is still not well understood. But it's thought to be due to a maladaptation of the adaptive immune response that skews towards a Th2 phenotype, leading to Th1 suppression. And as we'll see later, many of the therapeutics are focused on the T cell response. So Currently, there is no cure for RRP. This current standard of care is surgery. 1, to establish a diagnosis, and 2, to treat the disease. Goals of surgery are going to be to reduce the tumor burden, improve the airway patency, and improve voice quality. However, surgery is not without risks. These patients may require multiple surgeries, some require them every few months, some requiring them every few years, but that's going to lead to scarring. They may have permanent hoarseness due to multiple surgeries that have caused that scar, and a significant increase in mental health disorders, plus the cost. So this was a paper that was presented at the International Papillomavirus Society meeting that basically took patients who were registered with the RRP Foundation. It was about 120 patients, and basically looked at economic and social factors with them. They found that 80% of patients experience social isolation due to their disease. They're traveling long distances. 40% may travel anywhere from 21 to 100 miles to get care, and some even going higher than that. I think we're a little privileged being here in the Northeast. You can find a laryngologist almost anywhere within a relatively short distance, but that's not the case for much of the rest of the country. And about 40% of those patients suffer from depression, so almost half because of their disease. And a lot of that is because the fact that it is recurrent, it's not a one and done. So many of these patients have expressed an interest in, is there a cure? Can I get rid of this completely? And we'll focus on that a little bit later in the talk. Couple different techniques for surgery, and I'm sure you guys have had, all the residents have had this experience with Dr. Abughanim and Dr. Bensianov, but you can use laser, CO2, KTP, and now the blue light. Cold steel used a little less commonly, and then microdebrider. But the interesting thing with the technique that we use is that in general, vascular growth appears to be a universal pathologic contributor to RRP. So surgical techniques focused on that have vascular properties, like the KTP laser and the blue light laser, may have greater efficacy in treating RRP. And Dr. Zeitels and his group looked at that in 2009. So they combined topical intralesional bevacizumab with the KTP laser. And he found that coupling them both together improved response both anatomically and functionally. Now, he looked at resolution of disease. One of the patients in his study out of 20 had complete resolution after 4 intralesional injections of bevacizumab. 16 out of the total had some degree of benefit. So it looks like this may, in general, the photoangiolytic lasers coupled with intralesional injections may be better than just doing one or the other. Interestingly, the blue light laser is also emerging as effective therapy, and the nice thing about this laser is it has the photoangiolytic and cutting capabilities, so it combines the best of the KTP and the CO2. And in a study by Miller, they did find statistically significant improvements in the VHI-10 after using this laser for a variety of indications, including papilloma. So I'm sure you guys have seen this many times before, but this is a patient with RRP. We'll just see what the strobe looks like here.
Recording.
And say E. So you see pretty localized papilloma, not too severe, predominantly involving the posterior aspect of the right true vocal fold, and she has a little bit of disease on the left side as well. Give me a gentle E and hold. And then here's an example using the in-office KTP laser. It can be used in the office, in the operating room. And here's an example of what that looks like here. And so you see, in general, we can first use the laser on non-contact mode, and then on contact mode, we'll shortly see that kind of characteristic white blanch where you ablate the papilloma, and then it can just sort of slough off over time. All right, and then we see post-operatively what that looks like here. She's had good resolution of her disease. Glide from low to high on E, so go E. Sorry, the syncing is a little off, but you see she has a nice preserved mucosal wave. She has pretty good voicing after this in general, but her disease is also pretty amenable to this. You can imagine for patients who have much more severe papilloma, the more surgery that you do, the more scarring that you can get. Now, beyond surgery, how about adjuvant therapies? So kind of two main adjuvant therapies are out there. First was intralesional cidofovir, which was used quite commonly in the past, but there has been mixed success with it. There were concerns about the development of carcinoma in rats. They developed mammary adenocarcinoma, so some folks did move away from it due to that concern for malignant potential, but it's never really been shown in humans. In any case, a 2012 Cochrane review showed that there was insufficient evidence to suggest this over placebo and tends to be used a lot less commonly now. Intralesional bevacizumab has shown some promise. It's a monoclonal antibody, inhibits VEGF, and has been combined with the angiolytic laser. The systematic review suggested that there was potential benefit, but really there is limited data. All of these are small case series, 15, 20 patients. Many of the data that folks look at is a little bit subjective. They're looking at intersurgical intervals, which by nature is subjective because the decision of when to take a patient back for surgery is a little bit biased by the provider choice, also by the patient choice. If there's a patient out there who really needs their voice, they may be electing for surgery more commonly than somebody who does not. So in general, I think the jury is still out on how successful intralesional bevacizumab still is. Interestingly, what's the role for the HPV vaccine? So a little history of the HPV vaccine. First came out in 2004 with the bivalent vaccine focused on types 16 and 18, then the quadrivalent in 2006, and now the nonavalent. So this begs a question. This is a disease, it's mediated by the HPV virus. What is a role for the HPV vaccine, if any, both prophylactically and perisurgically? So this was a literature review. This is still in submission right now, but basically we were looking at, does the prophylactic HPV vaccine play a role in treating RRP? So we did a scoping review of 39 articles on the benefits of the vaccine when administered either prophylactically or perisurgically. Many papers did show that there was an increase in the intersurgical interval after perisurgical vaccination, and a clinical benefit was identified, although again, the research is quite limited. As we mentioned, that intersurgical interval is highly subjective. The Durkheim score is a more accurate way of grading the degree of papilloma, but not all the studies really include that. So basically, our bottom line was that there is a clinical benefit, but research is limited, and there is a need for a multi-centered research trial. The prophylactic HPV vaccination has shown significant effect. So this was a paper by Novakovic et al. From Australia, and so they looked at the incidence of specifically juvenile onset RRP after implementation of a national HPV vaccination program, which they launched in 2007. And they did find a significant increase in the incidence of juvenile onset from 0.16 to 0.02 cases per 100,000. And so it has been my practice typically to recommend that all folks get the HPV vaccine regardless of age. Anecdotally, one patient's had complete resolution of their disease, others have been stable, and really no systemic side effects or adverse reactions have been reported. And I think based on this data, we have good evidence to encourage HPV vaccination in children as well. So how does it work? With one thought is there was one study from Makiyama out of Japan. They found high rates of HPV DNA seroconversion after vaccination. So this supports the theory that potentially perisurgical administration of the HPV vaccine can induce mucosal immunity and neutralize the remnant viral load. So kind of looking next at emerging therapies. So we've seen surgery's been the standard of care, mixed success on adjuvant treatment. The HPV vaccine is promising, but what can we do for patients who have severe disease? And that brings us to the role of systemic treatment. So again, as we mentioned, surgery is only aimed at symptoms. It doesn't achieve cure. Repeated debulking surgeries can lead to sclerotic scar, webbing, stenosis, and significant mental health issues. Patients may suffer from PTSD, anxiety, and depression. And as part of my work with the RRP Foundation, I attended the RRP Roundtable meeting, which is just a meeting of folks who do research in RRP, HPV. And the interesting thing about that meeting is that patients come to it as well, typically patients who've had a role for the RRP Foundation. And the interesting thing that came out is that the patient perspective was that we are tired of surgery. We want a cure for this. We're traveling long distance. We're having scarring. We're having all sorts of issues. And it does seem to be that there is kind of a growing paradigm shift, moving away from surgery and potentially towards more systemic treatment aimed at cure. So the first option for systemic treatment is systemic bevacizumab. It's been FDA approved for multiple cancers. The first use for it was reported in 2009 in the pediatric population. This was a kid who had severe pulmonary and tracheal disease, and that patient experienced rapid improvement in their disease after administration of systemic bevacizumab. Laryngeal tissue from RP demonstrates higher levels of VEGF, so it's thought that it targets this to reduce the growth of papilloma. Side effects are fairly mild. They've been reported to be hypertension, proteinuria, some cases of hemorrhage, and typically the medication will be administered by a medical oncologist who will monitor those patients for side effects and also administer the infusions. Because of this incredible response to bevacizumab, there have been 2 clinical consensus statements that came out. The first was by Seidel, a large group of practitioners who wrote an international consensus statement on the role of systemic bevacizumab. This was followed by another paper from BEST, another consensus statement that actually focused on how to dose bevacizumab. And what the key highlights from the paper are, one is identifying patients who are candidates for it. So this is going to be patients who have severe disease. They need frequent intervention. So typically more than 4 surgeries a year is the criteria that they used. If they have instability of their voice, breathing issues, there may not be good surgical candidates, and patients who have a tracheostomy that cannot be decannulated. The interesting thing that came out of the BEST paper is that they recommended that this should be considered as a treatment option and offered to all patients regardless of disease severity, which is an interesting shift because in the past we were really reserving this only for patients who had severe disease. In terms of the dosing regimen, typically it occurs at 3 to 4 week intervals. Periodic laryngoscopies and bronchoscopies should be performed to monitor for response. And then they also recommended lengthening the treatment intervals over time so that you're using it as less frequently as you need to. And the last thing that it highlighted was a multidisciplinary approach. So again, so this should be otolaryngologists should be involved. If the patients have pulmonary disease, interventional pulmonologist or thoracic surgeon, and then finally medical oncology. Interestingly, new therapeutics are also in the pipeline. First is INO-31017. This is a study that I should preface was sponsored by the drug company, and many of the authors on the study do have financial ties. But in any case, it's a DNA immunotherapy. It elicits a T-cell response against HPV type 6 and 11. This was a phase 1 or 2 trial, so really it's just assessing the safety of it and early efficacy. So they looked at 32 patients, 7 of those had juvenile onset, 25 had adult onset, and they administered 4 intramuscular injections. 41% had low-grade adverse events, so these are going to be things like pain, fatigue, injection site bruising. Interestingly, 81% experienced a reduction in the number of surgeries. Again, this is a little bit of an artificial marker as that intersurgical interval is variable, but in looking at it for patient to patient, in each specific patient, that intersurgical interval was increased over time. So I think this is an interesting new potential therapeutic, but certainly more research needs to be done with larger sets of patients. The other therapeutic that's come out is called PRGN 2012. This one is a gorilla adenovirus immune therapeutic, technically a vaccine, but in today's political climate, I think the terminology is also shifting. But basically, it enhances HPV 6 and 11 T-cell immunity. They also did an early phase 1 trial, looked at 15 patients, and what you see here is they had selected complete responders. They found an overall 53% response rate. These were patients who completely responded. So you can see here, patient with papilloma really localized to the larynx. This is them at 22 months. Another patient at 21, 20, and 19 months. all essentially with complete resolution of the disease. Now the question is, how long do you treat them for? Do they need to continue getting treatment? With bevacizumab, we've typically seen that if they stop the infusions, their disease does come back. With these, we still do not know because they just monitor patients for the duration of the treatments. And then finally, I wanted to kind of end with some work on pulmonary RRP that we've done. And I think pulmonary RRP is something that's present, but really not, I think, on the radar of most otolaryngologists, I would say. And basically with pulmonary disease, this is going to involve papilloma within the terminal bronchioles and pulmonary parenchyma. And most of these patients are going to have disease that's detected on imaging for other indications. The interesting thing is that it's present in almost 9% of patients, and when it is present, these patients have a 32-fold increased risk of malignant transformation. So when we think about the mortality of the disease, we've talked a lot about the morbidity, but when we talk about the mortality, in most cases, that's going to happen because of airway obstruction or because of pulmonary disease. And these patients are going to present typically with recurrent pneumonia or tracheobronchitis. What you'll see on chest imaging, they can have solitary nodules or cavitary nodules. So this is an example of a patient with a cavitary nodule here. Here are some solid nodules in this picture. And then finally, in the last one here, you see a small nodule that's in the right mainstem bronchus. They're typically variable, or they're typically bilateral. They can be variable in size, and they do have a predilection for the posterior aspects of the upper and lower lobes. And so because of this data, I've done some work with the RRP Foundation and been on the pulmonary RRP working group, but our thought was to write the clinical consensus statement on pulmonary disease. So given the potential prevalence and potential morbidity, mortality, and high risk of malignant transformation, there is a significant scarcity of data. We really have very small studies that focus on this. So our thought was to write this to have a standardized approach for detection and management, because if we're not imaging patients consistently and looking at their responses over time, we're not really going to know, A, what's out there, and also B, whether a lot of these new therapeutics are going to be effective at treating the pulmonary component of disease as well. In disclosure, the results of this were presented at the CASA meeting, and they're currently submitted to Laryngoscope. So I'll just go through a little bit of our methods on this paper. Basically what we did was we assembled a pulmonary RRP expert group. So it combined providers in adult and pediatric otolaryngology, thoracic surgery, pulmonology, medical oncology, pathology, and radiology. And finally, we had a representative from the RRP Foundation to capture the patient perspective. We then proceeded with a modified Delphi method, which is a group consensus technique. A panel of experts conduct surveys and discussions on a variety of statements to reach consensus. And in this case, we looked at 4 main categories: screening, management, diagnosis, and treatment. And so first, our core working group did an extensive literature review. We crafted initial statements based on working knowledge of common clinical practices. We then disseminated those statements to the broader working group, which comprised of 19 individuals, and they added a category on for systemic treatment and came up with a total of 49 statements. After that point, we had 3 iterative surveys. Participants all ranked the statements, rating how much they agreed with them based on a Likert score, and that was completely anonymized. After each survey, we held a video meeting. The language of all the statements was crafted to refine the clarity of all those statements, and ultimately 33 met consensus. So we'll just highlight some of the key statements that the majority of the group focused on in the next couple slides. So with regards to screening, we all agreed on performing HPV typing upon diagnosis of RRP. There was not a need to repeat HPV typing based on the work that HPV subtypes tend to persist in individuals. The second thing was a role for screening chest CT. So it was a recommendation of the group that for adult onset, this be performed at this time of diagnosis, so non-contrast CT chest. For juvenile onset at either age 21 or 7 years after the diagnosis, based on the data that this is typically when the pulmonary lesions appear. And one kind of key statement that went throughout all of these different categories was that shared decision-making should be undertaken with a multidisciplinary team. So as otolaryngologists, we're obviously usually the first people to see the patients, but we know nothing about pulmonary management of pulmonary squamous cell carcinoma arising in the setting of RRP. So we recommended a multidisciplinary group with thoracic surgeons, interventional pulmonologists, and I think also the key is radiologists and pathologists who are experienced in pulmonary disease and can assess whether these are routine nodules or whether they may potentially be concerning for pulmonary RRP. With respect to diagnosis, there was a recommendation for biopsy and nodal sampling in patients who have cavitary pulmonary disease and enlarged mediastinal or hilar lymphadenopathy. And in cases of malignant transformation, a PET CT and mediastinal staging was recommended. With respect to management, we also recommended that surveillance be continued. So even if no pulmonary lesions are identified on the initial CT chest, there was a recommendation to continue surveillance with an annual low-dose chest CT. And with respect to treatment, there was a recommendation for consideration of systemic treatment as well as clinical trials. Pulmonary disease is hard to access. It's not as easy as the larynx, and so surgery may be associated with higher complications and greater difficulty. So there was a thought that systemic therapy should be considered more so in these individuals. A couple limitations of the study. It's certainly a modified Delphi method. It favors groupthink. Even though the surveys are anonymized, folks may be influenced by those who are more vocal participants. And I think the last point really highlights the limitations of our understanding of pulmonary disease, and that's the fact that there is a lack of high-quality evidence on pulmonary RRP in the form of clinical trials, meta-analyses, and basic science tissue evaluation. So for that reason, this was a clinical consensus statement and not a guideline, but it was the hope that this brings more attention to the disease so we can get more data and understand the course better. So in conclusion, I kind of want to highlight a couple of key points. One is that we may have a paradigm shift in the treatment of RRP away from surgical and potentially towards more systemic treatment. And I want to highlight that most of this is going to be offered in patients with severe disease, but it does appear that patients are looking more for curative treatment rather than having to come back for repeated surgeries. I think there's strong evidence that we do have for the efficacy of the HPV vaccination prophylactically, at least prophylactically based on our data from Australia and potentially perisurgically as well. With respect to pulmonary RRP, this is a rare, complex disease that does benefit from a multidisciplinary care team, and there is a need for further research to further characterize the natural history and biology of the disease and then to develop novel therapeutic options. Here are my references. And I just want to thank everyone for the opportunity to present today, and I'll be happy to take any questions.
Those aspects.
I think for prevention, certainly vaccination is HPV vaccination. If there is known papilloma, like in the mother, that we have diagnosed, then I believe the recommendation is for a C-section after. But I think those would be the two main points.
When you say if there is papilloma, you mean like a previous sibling?
Or if the mother has
papilloma, I mean, you just said that 80% of women will have papilloma.
Or 80% of women will have HPV, but not necessarily papilloma. So I think if they have active papilloma cervically, then in those cases, then vaginal birth was not recommended.
Okay, thanks.
Very good talk, Nikita. Thank you very much. I wanted to ask you, we've obviously noted a lot of HPV-related cancer in the head and neck. Is there similar work going on in the chest? Is there an uptick in HPV-related squamous cancer in the chest? And is that associated with papillomas or just generally?
Yeah, in terms of if there's primary HPV-associated carcinoma in the chest, not associated with papilloma, that I don't know about. I don't think that we've seen it, but I don't know for certain about that. Certainly carcinoma in the setting of pulmonary squamous cell carcinoma in the setting of papilloma has been described, but I'm not certain about primary HPV-related squamous cell carcinoma. All right, thank you.